Look, I don't care about the risks, so why should you? The meds are the only thing that make me feel better.
Well, I can see how this is a problem for some people, but I'm doing fine. Why change the plan?
I told you I don't have a drug problem. My problem is pain.
Unfortunately, opioids have other problems, particularly at high doses. Your dose has crept up past the safe point, and we need to work together to bring you down to a safer level.
If you prescribe opioids, you've probably been in this situation. You have clear evidence. The appropriate medical decision is to taper these medications, but your patient absolutely refuses. In practice, there are few situations more frustrating and unpleasant for both you and your patient. All too often, the end result is that you find yourself alone with a patient who is both overwhelmed and overwhelming, caught between what you know you should do and what you find you really can do. When your patient is being exposed to undue risk because of comorbid conditions and signs of aberrant behavior or a lack of functional benefit, the question is not if the patient should be tapered or weaned, but how. The purpose of this video is to make these very difficult situations a little bit easier for you and a lot more helpful for your patient. Collaborative opioid tapering is a process of transferring hope from opioids to self-management efforts. Your goal is to assure safety while educating and supporting your patient. It requires a careful risk-benefit analysis and appreciation of the patient's perspective, as well as other life problems, and an awareness of your own emotional reactions during these difficult conversations. Following 3 scenarios depict clinical interactions with patients for whom the guidelines suggest tapering is indicated. Each scenario includes an analysis of the interaction and models helpful responses to common statements and pleas and accusations that providers often find difficult. First, a patient whose comorbid conditions put him at elevated risk for an adverse event. Second, a patient with a history of high-risk aberrant behavior. And third, a patient showing no functional benefit. Once you've decided to taper opioids, it's essential that you prepare your patient for the change in treatment plan. Sometimes providers don't handle this process as sensitively as they should, often because they don't know how to have the conversation productively. They may cite new national guidelines, research, or express concerns about their license as the motivating factor. They may abruptly taper opioids for patients who are justifiably confused and feel threatened by the sudden change in pain treatment. A more helpful first step is to schedule a visit, focusing on education and reassurance before beginning the actual dose reduction. Give your patient time to digest the information you provide. Encourage them to do research to verify your concerns and the reasons for the change in treatment. Remember, it's understandable if the patient's first reaction is negative and they don't seem open to making a change in their opioid dose. During preparation, reassure your patient that you are not abandoning them, but will develop a reasonable plan together that sets them up for success. It will be collaborative and you will communicate with each other along the way. This includes tapering at a thoughtful pace so that uncomfortable side effects are minimized. Be prepared to review non-opioid treatment options and facilitate access to these services. Coordinate with your mental health or addiction treatment teams immediately if these issues are relevant. Developing and discussing a concrete treatment plan goes a long way in lessening patient fears and building a collaborative relationship. Have a detailed discussion about the tapering plan and make it very clear when that program will begin. For someone actively abusing substances and refusing offers of treatment, beginning the taper immediately may be indicated. For others who have no urgent risk but object to tapering, an additional visit to address concerns may be in order. If they do not agree to taper, a discussion regarding transfer of care may be needed. Most patients will understand the need to taper and will be reassured by the collaborative approach that addresses their fears and individualizes their treatment. It's important to note that some patients have opioid use disorder. And it's critical to appropriately diagnose and triage those individuals. If you're unsure about whether the patient you are seeing meets the criteria for OUD and related treatment, refer them for immediate evaluation so that a provider with expertise in OUD can help create the best plan of care. Let's meet our first patient. Mr. Andrew Jones is a 65-year-old male, generally in good health, who's been using opioids for many years. He's retired and financially stable. He and his wife are active and enjoying life. His current dose of 100 MED is outside of the guideline recommendations, and his provider wants to begin a taper plan.
Mr. Jones, come on in. How are you today?
Hello, Dr. Dawson.
Good to see you. How is your wife?
Oh, she's doing great. Always in her garden.
Oh, I am sure she is.
Begin with an assessment of the patient's understanding of the problem.
Mr. Jones, I'd like to talk to you about your opioid medications. Have you heard about some of the problems with these medications on the news?
Sure, but I don't see what a bunch of people getting hooked on heroin has to do with me. I take the medications that are given to me by doctors for pain. I'm not an addict.
Of course you're not, but the pain medicine you are taking is very similar to heroin and has some of the same problems.
Well, I don't know anything about that. I take the medications as prescribed. I've been on this for years.
Patient confusion is understandable. Education is essential.
That's true, but over the years your dose has gradually increased, and at your current level, you're at risk for some very serious health complications. It's one of the problems with opioids. Your body gets used to the medicine, and you need more to get the same effect. It's called tolerance, and lots of medications have the same problem.
So what's the big deal with my pain medication?
Good question. Unfortunately, opioids have other problems, particularly at high doses. Your dose has crept up past the safe point, and we need to work together to bring you down to a safer level.
I don't get why all the fuss now.
Well, your problems with breathing at night. Sleep apnea makes this a real concern.
I've had that problem for years, though, and nothing else helps me as much as the pills.
Written materials are very helpful.
I tell you what, let's not get into the details right now. We're not making any changes today. I have some handouts for you to look over in the next month. Here's some information on the new opioid guidelines and a couple of links to some pain management websites. Both have lots of good information about pain. You do a little homework, and I think it will make it clearer why we have to come up with a better plan to help you with your pain.
Okay, I'll check it out. But what if I want to stay on my same medication?
Be clear about the need to change the plan, and use we to communicate collaboration.
There are more effective and safer ways to treat your pain. Let's make sure we take advantage of that. We'll work together to get you down gradually to minimize any discomfort. It shouldn't be a problem.
What about my pain? What are you going to do about that?
There are lots of things we can do, but we'll talk more about that next month. First, let's make sure we're not going to harm you. Then we can talk about how we can help you. We'll come up with a plan that is safe, sensible, and sustainable.
I have to be honest. I'm doing fine right now, and all of a sudden, you're talking about changing things. It's kind of freaking me out.
Thousands of healthcare providers and patients are having this same conversation, and I bet almost all the patients feel the same way. We have new information now, and we understand that there are safer ways to effectively treat chronic pain. Now that we know better, we have to do better. Try not to worry. I'm sure we can do this in a way that is comfortable for you in the short term and more helpful for you in the long term. But right now, I want to go over the instructions for the naloxone kit.
An essential conversation that communicates concern and mitigates risk.
Thanks for coming back in.
Begin with a follow-up for the homework assignment.
Mr. Jones, Have you had a chance to review the information about the new guidelines and reasons I'm concerned about your opioids?
Yes, I went to the websites and I read the paper. I even read about the naloxone kit you gave me. You got me scared, but I don't know if I agree with all of this.
Acknowledge and normalize the patient's fear. Continue assessment.
That's understandable. There's a lot of new information about these medications, and it's frightening. What questions do you have?
Well, I can see how this is a problem for some people, but I'm doing fine. Why change the plan?
I agree. You're doing fine. In fact, you seem to be doing great. My concern is that so far you've been very lucky, and counting on good luck is not a good care plan.
Lucky? What do you mean lucky?
I mean, your current dose and your sleep apnea put you at real risk someday for accidental overdose.
Overdose? How is that possible? I only take my regular dose.
Most overdose deaths are people who are taking their medications as prescribed. It's not just the person who mixes opioids with alcohol or street drugs.
I read that, but it doesn't make any sense.
Think of it this way.
Avoid medical jargon. Use plain talk and metaphors to communicate complex medical concepts.
It's like the person who is walking on thin ice. Everything looks safe right up until he falls through. These medications slow down your breathing, and when you are sleeping, you have a similar problem. So far, your body can handle it, but the combination of apnea and high-dose opioids is like thin ice. If your breathing gets worse due to the flu or your body changes with age, it's just like jumping up and down on that ice. If you keep at it, your luck may run out. We don't want that to happen.
So, what do we do to prevent that?
Let's go over the plan for the slow tapering and how we handle any discomfort you may feel. There's no need to rush as long as we're moving in the right direction. We can also talk about other ways to help you with your pain.
I hope so, because I'm still kind of worried about that.
It's normal to feel worried at this point.
Normalize concerns and provide reassurance of your support. Written plans and regular follow-up are important.
But we'll get through this together, and you have my phone number if you need to reach me. Many patients actually feel better once they are off these medications. They can think more clearly, and sometimes they even have less pain.
Our next patient, Mr. Mark Stevens, 42-year-old male with low back pain from a work injury 10 years ago. He has not returned to work and is pursuing Social Security disability for the third time. For the past 3 years, he's been under the care of a community provider who escalated his dose to 200 MED, but has recently retired. Earlier medical records suggest chronic problems with substance use disorder. This is the first visit with his new provider, Dr. Dawson.
Hello, Mr. Stevens. I'm Dr. Dawson, and I'll be working with you now that you're back in our system again. What brings you back?
I had no choice. My pain doc is retiring and I need pain meds, which I ran out of this morning.
I understand.
Begin to redefine the patient's problems as more than pain and helping as more than immediately refilling opioids.
I looked at your chart and see that in addition to your pain, you were getting help with several other problems the last time we saw you.
Yeah, maybe. But my biggest problem is the pain. That and the fact that no one seems to understand how much I hurt.
Respond empathically and attempt to build rapport.
A lot of patients with pain feel like providers don't get it. I hope we can change that today.
You can. Just give me the pain meds that my pain doc gave me. He was the pain specialist, so that means he knew what he was doing.
When patients challenge you by referring to the practices of other professionals, it is best simply to acknowledge that your policies are different. Be aware of defensive responses that seek to either justify your policies or criticize the practices of others.
I'm sure he did. But the dose he was giving you is way outside of our guidelines. We can't keep doing that, Mr. Stevens.
Outside of the guidelines?
There have been lots of changes in the way we prescribe opioids. Let's see if we can come up with a new plan to make sure your dose is safe.
I am safe. My problem is pain, and you people won't help me with that.
There are lots of ways to help you, not just with pain, but also with some of the other problems you seem to have been struggling with over the years.
Problems? What problems are you talking about?
Well, for one, I see you've had some serious problems with alcohol and other drugs. You've been in and out of treatment a few times, and it's been several years since your last treatment.
That's because I don't need it. I was getting the meds I needed from my pain doc. Hell, I was only using alcohol and drugs when you people wouldn't help me. Now, are you going to help me or not?
Patients who misuse opioid medications and/or other substances may argue that it's your fault they engage in risky behaviors. It's very easy to respond defensively or angrily to patients who act irresponsibly and accuse you of being the real problem. Avoid arguing or trying to convince your patient that they should follow the treatment plan. They will likely argue more strongly that they would be fine if you just gave them more opioids. Remember, you are not refusing to help. You are refusing to continue harm. Offer to help them with their primary problems while providing other pain treatments.
I certainly want to help you, but we have to make sure we're talking about the same thing.
That's what you want to do, all right? Just talk, and waste my time.
My first concern is for your safety, Mr. Stevens.
Clarify treatment priorities. Safety is more important than urgent pain relief.
Okay, so what does that mean?
That means that we need to start looking at other ways to manage your pain and figure out a better medication strategy. What I would like to do is to have you see someone who can do a more thorough evaluation to help us decide what the best treatment plan is for you. Would you be willing to do that?
Refer to addiction specialists to clarify questions of opioid or substance use disorders.
What kind of evaluation?
I'd like you to see a colleague, a psychologist from our opioid safety program. He can take a closer look at how you're doing and help you get back in treatment if you need it. We can coordinate your pain treatment with his team.
So that's your idea of helping me? Sending me to a shrink?
It's the start of getting you on a safe program.
Use risk mitigation strategies, including short-duration prescriptions and urine testing.
When you come back next week, we can talk about other ways to manage your pain. I'll give you a one-time refill at your old dose for 1 week to give you some time to see our psychologist. I'll also need you to give me a urine sample today. Are you taking any other drugs that I don't know about?
No. I told you what I'm taking. You think I'm lying?
No, not at all. The urine test is just another way to make sure we're not hurting you with these opioids. Here's some information about how to contact the psychologist for the evaluation. A handout about the new guidelines and some websites where you can get more information on non-opioid pain treatments. Look this over. And we'll talk next week. For now, let's go over the instructions for the naloxone kit. Mr. Stevens, how have you been this past week?
How do you think I've been? This has been the worst week of my entire life, thanks to you.
Respond empathically when emphasizing patient choice and responsibility.
I understand you're upset. We're talking about changing your pain treatment. I also see you chose not to follow up with the opioid safety program.
I told you I don't have a drug problem. My problem is pain. I hurt everywhere. I can't do anything. I can't keep living like this.
Some patients respond with threats when informed that their opioid medications will be tapered. It's understandable to be fearful when a patient suggests that they will harm themselves if you don't provide opioids. Consult with a mental health professional if your patient threatens self-harm, even if such statements are indirect.
Are you saying you're thinking about hurting yourself?
Follow up on all mention of suicide or self-harm. Clarify vague statements with direct questions.
Of course I am. Anyone would. Life sucks when you hurt as much as I do. Why are you putting me through this?
Avoid defensive responding to blame and continue suicide risk assessment.
Do you have a plan to hurt yourself?
Oh, so now we're doing the suicide thing? Don't worry, Doc. I'm not gonna kill myself, okay? So you can put the butterfly net away. I don't need a shrink. I just need my meds.
Okay, I'm glad to hear that. But you should know I take that kind of talk very seriously. We can help if you feel like giving up.
You can help me by getting me the medication that I need.
Actually, suicide risk is a reason to consider stopping these medications, not to give you more.
Well, forget I said it then. I don't know how you can be so heartless. It's your job to help me.
Many patient statements create confusion about our ethical and professional obligations. Avoid taking responsibility for urgent and complete pain relief in patients who refuse to engage in self-management efforts. You may not be able to help some patients, but you can always avoid doing harm. Be empathic but not apologetic. Keep focus on safety first.
I'm sorry you feel that way, but I really am trying to help you. It's just not safe to continue the way things were going, and after seeing your urine test results, it's very clear that something has to change.
All right. You got me. I smoked some weed. Big deal.
That can be a problem, but I am more concerned about the fact that you're taking medications that are not being prescribed. In particular, the benzodiazepines and a different opioid.
I can't sleep because of pain. A friend gave me a sleeping pill and a couple of pain pills when I was out. I told you I needed more meds last time I saw you.
You did, but using other people's medications is a bad idea.
Okay, fine.
The pill you took is really dangerous, especially in combination with opioids. Even worse if you drink.
So what do you suggest I do about my pain?
That depends on your preferences.
Assess patient interest and preferences in treatments other than opioids.
Did you look at the information I gave you?
Yeah, right. You want to give me some acupuncture or some of that psychology crap. It doesn't work. I've tried it. I'm better going back to the bottle or buying something off the street. Is that what you want?
Those aren't choices I recommend.
Avoid arguments. Emphasize patient autonomy and responsibility. Be aware of illogical thinking that supports continuing bad care in the guise of harm reduction.
And the choices you do make limit the options we have. But as I said, at this point, my first concern is your safety.
Listen, lady, I have a pain problem, not a drug problem.
Clarify your diagnostic impression and outline the treatment plan.
It's really not an either-or situation. I think you have both problems. Your best bet is to treat both problems at the same time.
Not interested.
I understand, but I'd still like to refer you again to the Addiction Treatment Center for an evaluation.
This is so... So, what are you gonna do if I won't go? You gonna cut me off, kick me out the door?
Set limits and emphasize patient control of the available options.
I'm still hoping that won't be your decision. I'm certainly willing to give you some medications to help with any withdrawal symptoms. What I am not willing to do is give you opioids if you're not engaged in addictions treatment.
If I go get the evaluation, will you get me the medication that I need?
If you make that decision, we'll work together with the entire team to get the kinds of treatment you need. I can't tell you for sure until you go see them, but high-dose opioids are clearly not appropriate in your case. Are you willing to go see the addiction treatment team?
Do I have a choice?
You always have choices.
It doesn't feel like that to me. I guess I'll go see the shrink, even if it is a lot of BS.
Okay, I understand how you can feel that way right now, but you've been through addictions treatment before, and maybe this time it will be more helpful. I'm hoping we can work together and come up with an effective long-term pain treatment plan that is much more safe and sensible than opioids.
Next patient. Ms. Vega is a 31-year-old female with fibromyalgia and significant trauma history. She was hospitalized last year for suicidal ideation. She's in treatment for depression and PTSD. She's unable to work and spends most of her time isolated and inactive because of pain. She is being seen for routine follow-up.
I haven't seen you for a couple of months, Miss Vega. I can see from your chart you've been having a rough time. What's going on?
More of the same. The pain is actually getting worse, and I can't do anything. It really makes me depressed.
Respond empathically and begin to redefine the clinical problem from a pain problem to life problems.
Sounds like life is hard for you right now. I know it's been like that for a long time.
I'm just so exhausted. I can't sleep because I hurt too much, and then the next day I can't seem to find enough energy to do anything.
Emphasize reciprocal relationship between pain and depression, and follow up on self-management efforts.
You're stuck in that cycle where pain makes your depression worse, and depression makes your pain worse. I know you're working with your psychologist on your depression. What have you been doing to help yourself with the pain?
I told you before, my pain is so bad that I stay in bed most of the time. My family doesn't even know if I'm dead or alive after I shut the door.
We both know isolation and inactivity can make depression and pain worse. Did you get started on that daily walking program we discussed at the last visit? You seemed to think that was a really good idea.
I went out a couple of times. It just hurts too much to walk.
Normalize increased pain due to deconditioning. Introduce concepts of a lack of functional benefits and potential opioid harms.
Well, like we've discussed, you have to expect more pain when you use muscles that you haven't used in a long time. According to what you're telling me, it's clear that the opioids aren't making any real difference in how you get along every day.
What do you mean?
You're stuck in bed most of the time. Actually, I think the opioids are probably hurting you by making you more tired and slowing you down.
But I was going to ask you to increase my dose today.
Many patients who are functioning very poorly or complaining of severe pain will strongly resist tapering in spite of the fact that they are showing no obvious benefit. From their perspective, opioids help because they temporarily reduce the pain and help them feel better. Pain and suffering are inextricably linked, and opioids may be indirectly and ineffectively treating emotional problems such as depression, anxiety, and PTSD.
Then it's a good thing we have this appointment today.
Introduce collaborative tapering. Encourage hope for other treatment options. Reassure patient of individualized plan.
Let's see if we can work together to come up with a new plan that's safer and more effective.
The old plan might work if you'd give me one more pill a day.
Respond empathically. Maintain focus on function. Clearly communicate a change is needed.
I can understand why you might think that, but we can't just keep increasing the dose. We won't make any changes today, but...
All I want is for a little relief for a short time. That would be a blessing.
Miss Vega, unfortunately, there's no easy fix for chronic pain. These medications may help take the edge off temporarily, but they obviously are not helping you function in your daily life. If you're not benefiting from the opioids, it's not worth the risk to even keep you at the dose that you're on.
Look, I don't care about the risks, so why should you? The meds are the only thing that make me feel better.
It's easy to get confused about your responsibility when the patient is willing to absolve you for the decision to ignore the risks. The fact is, these are your decisions and responsibilities, not those of your patient. Your first duty is to do no harm. They may be willing to take the risks, but you are not.
That's not surprising. Opioids work great for a few hours, not just on pain, but also on your mood.
So, what's wrong with that?
The problem is we now understand that over the long term, benefits go down, but risks go up. We want to be able to treat you in a way that gives you greater benefit for a longer period of time. It's not enough to just feel better. You have to be doing better in order to justify the risk.
What do you mean I have to be doing better?
Be specific when talking about function. Acknowledge self-management as difficult but essential.
I'm talking about getting more active and engaged in everyday life, taking care of chores, participating in family activities, doing all the important things we've discussed in the past that have been so difficult. I know it's hard, but the real solutions are learning self-management skills and changing the way you respond when you hurt. These medications are short-term solutions that create long-term problems.
Okay. Look, I promise if you just help me out this one time, I will start walking. I'll even go to physical therapy or that psych group if that's what you want.
Patients may attempt to negotiate. Promises may be made to change long-standing patterns of noncompliance with rehabilitation efforts. Monitor your own sense of hopefulness in the context of your history with the patient. If the decision to taper, wean, is based on a lack of functional improvement, doing more of what hasn't worked in the past is not likely to work in the future.
What I want is to work with you to develop a long-term plan that is safe and effective. It really makes no sense to keep doing the same thing over and over again, expecting a different result. That's the definition of insanity, right?
Do you think I want to be on these meds? I want to come off them. I'm just not ready.
Miss Vega, I know you're doing the best you can right now.
But I could do better. Just don't take my pain meds away.
Avoid blaming the patient. Express confidence in the patient while doubting the treatment plan.
I believe in you, Miss Vega. It's the treatment plan I'm doubting.
What's insane is that you don't seem to care about what I'm going through. Maybe if you had my kind of pain, you'd understand.
Perhaps most difficult are the statements that challenge you personally. When a patient accuses you of not caring, be aware of your own reactions. Be alert for desires to prove your compassion by giving in to requests for opioids.
I can see you're angry and upset. That's understandable. But no one is talking about cutting you off suddenly and completely. We're not even going to change anything this visit.
None of this makes sense to me.
Express empathy and normalize strong emotional reactions. Reassure the patient of your support during this process.
Change can be hard, but we've learned a lot about these medications and there are better ways to help you. I've got a handout for you. They have some websites and high-quality pain information. We'll talk some more about this next month at our visit, and we'll look at other pain management options. I'm sure we can come up with a plan that is safer and more helpful. We can do all this slowly, and I can help with any discomfort.
I can't believe you're doing this to me. You realize my depression is already off the charts because of my pain. What are you trying to do? Push me over the edge?
That's the last thing in the world I want. I've already talked with your psychologist who is helping you with your PTSD and trauma work.
Know your patient and be prepared for understandable and predictable declines in functioning. Collaborate with mental health providers when tapering high-risk patients.
In fact, she saved some time for you right after this appointment so you can talk. We'll all work together on this. There's no rush, as long as we're heading in the right direction.
Opioid tapering can be very distressing for both patients and providers. Guidelines are very clear about when opioids should be tapered, but are much less helpful with suggestions about how this will occur. Collaborative opioid tapering requires an appreciation of the patient's perspective, as well as an awareness of your own emotional reactions during these difficult conversations. Our hope is that this video helps you have more useful and effective conversations with your patient about opioids. Sometimes your patient may not appear to appreciate your efforts while tapering, but remember, They need your help now more than ever.